All right, welcome everybody. I'm Dr. Ronald Peterson. I work with Whitehall. Wes will be joining us later, I believe. I know he had a conflict at this time. He asked me if I would speak with you today about what we call two-step perio. For those of you who don't know, I am a retired periodontist, so near and dear to my heart topic. And if you have questions at any time, of course, please let me know and we will acknowledge you and see what we can do to answer the question. A little background. We, in Whitehall, as you know, we see offices from all over the country. And about 10, 12 years ago, an office in Florida was having a problem. They were doing a lot of marketing. It was really two dentists. One was part-time. They did mostly mail marketing at that time, which was the common form. And we're seeing 100 to 120 new patients per month on average, which should be enough to keep an office with two doctors quite busy. But the problem was the office was actually spiraling downward. The production was down. Hygiene had gone from three full-time hygienists down to one and a half. And of course, hygiene being a strong base for restorative care, we don't like to see that happen. So after looking at the office, we decided to try to figure out what was happening with these patients. 120 new patients a month. What happened to them? So we put together what's called a retrospective study, where you go back and look at what happened to something from a previous moment in time. The structure was set up to go back roughly 14 months and look at 100 consecutive new patients that were seen at that time. We then broke those into three categories, one being people who had an examination and never returned to the office. Second was people who, of course, had the examination, came back for something, and were no longer active in the office. And then the third group was people who were still active in the office. When we looked at the numbers, it was startling. 90% of the new patients that were seen 14 months earlier were no longer active in the practice. So that was obviously a sign that there was something major going on. So we wanted to dig deeper and see what that was. And we finally found what it was. It was perio and how it was presented. There are several things that can happen uh, that can cause patients to not commit to your office. They can be overwhelmed. There can be financial issues. There can be people that really just don't understand the treatment. It's not explained well enough to them. You all know that these are major issues. In fact, I believe it was Shine did a white paper toward the end of last year comparing the average dental office, restorative dentist office, to the top 10% of offices based on finances, and they found several interesting things. One of them was the average dental office closes roughly 45% of the new patients that they see, closing meaning that they come back and become active long-term patients. And the offices that are in the top 10%, their success rate for closing is 89 plus percent. So there's a big difference in the process and, of course, how patients are treated. But going back to this particular office, we found that almost without fail, these patients who didn't come back at all or did come back were diagnosed with periodontal disease and told through the treatment plan discussion that they needed 4 quadrants of root planing and scaling. Now, I'll get into this just a little more. The part of the problem was the treatment was being overdiagnosed. Okay, but that's a totally different issue. The real problem was one of two other things. Patients that think they're in good shape and they're paying, let's say, $99 for a new patient special exam, x-ray, cleaning, and come into the office and they're told, oh, you don't qualify for that. You need 4 quadrants of root planing, and that's $1,200. That patients then think that that's a bait and switch. And even if it is not a bait and switch, as it should never be, it still can be overwhelming. When patients come in for a new patient special, for whatever amount that is, that's what they should be charged for that day. If they need further treatment, obviously, that's a different issue. So this second group of people had their root planing done and still didn't come back. And we found the issue there was, for the most part, 4 quadrants of root planing was completed by their hygienist in 90 minutes. I've done a lot of root planing myself. There's no way I could do 4 quadrants of root planing in 90 minutes. So that was again, a separate issue. But getting down to the assumptions, let's say that these people do have significant periodontal disease, particularly some inflammatory issues with bleeding, swelling, so forth, and they're really not aware that they have a problem. How do you approach them? How do you discuss that with them? And how do you convince them in that short period of time that you have them in that initial examination to become a treatment or become a patient, and that the treatment that they need is necessary? So, putting aside all of the potential unethical parts of that presentation, it did lead us to, what do you do with patients that need periodontal disease? They're new to your office, they don't know you, that they don't necessarily trust you, and presenting them with 4 quadrants of root planing at that first visit is almost a guarantee you'll never see them again. So here's what we worked out, and it's worked very well. We've been doing this now for a good 10 years. A good number of offices use this, but here's the type of patient it's really designed for, and that isn't your referral from a next door neighbor or from an existing patient. Those people come in, they know you, or at least they know of you, they trust you, or they have a level of belief in you because of who sent them to you. I'm talking about really patients that are a lot more questioning or fragile, I guess, as far as it doesn't take much to lose them. If they have a periodontal problem, here's what should be done. Of course, the hygienist should explain, Mr. Peterson, you have some periodontal issues. Explain what that is, show what it is, use probe, all the techniques that we were all taught and the hygienists were taught in explaining to patients what periodontal disease is: pocketing, swelling, infection, stressing the point that this is an infection, because it is. There's lots of studies of what bacteria are in there, and in my entire career in dentistry now, which is a lot of years, and almost all of those as a periodontist, we find new bacteria, new infective agents all the time. So there's no one bacteria that causes periodontal disease. It's a change of flora, and there are some very aggressive ones, but that's kind of beside the point for this talk. We need to let the patient know they have an infection and what that can lead to, and show them what is going on in their mouth: some bleeding, some calculus, some tartar if it's there. Show them with your films, show them with your scans, and with your photographs. Explain to them that this is an infection and it doesn't go away on its own. Now, the approach should then be, especially a patient that's coming in on a new patient special. A new patient special doesn't say exam, x-ray, and 4 quadrants of root planing. It says exam, x-ray, cleaning. So you give them what they came for. You have the hygienist use their scaler and do a debridement, and do it within the time allotted. And that may only be 20 minutes or so, and that may mean 20 minutes with a Cavitron. Cleaning up as much as you can in the time that is allotted, and showing the patient what changes you've made, and polish the teeth. You always polish the teeth because patients don't think they've had their teeth cleaned if you don't polish them. However, when you're done, or when she's done, she should explain that this is an infection. I've done what we could do in the time allotted. The doctor will be in, and I'm going to ask the doctor to look at you and put you on an antibiotic because this is an infection. We will then like to see you back in 30 days to see how much improvement we have and how much further treatment, if any, will be necessary or recommended. You then give them brochures about periodontal disease, and frankly, that 30 days gives them time to own the fact that they have a problem. If they came in not knowing they had a problem, not thinking they had a problem, you're going to give them time now to check it out. The antibiotic, people say, why the antibiotic? Well, the antibiotic I recommend is doxycycline hyclate, 100 milligram tablets. Give him 10 tablets, 1 per day until gone. Doxycycline is one of the most effective broad spectrum antibiotics that is effective with many of the known periodontal pathogens. It really helps, particularly if you have instances with some swelling, some bleeding, some inflammation, even a little drainage. Just a debridement and antibiotic will really make a huge improvement with that patient. When the patient comes back, they should understand and know at this point that there's a problem. They're going to be pulling their lip down during that month and looking at their gums, seeing what changes there are. And when they come back, the attitude will be different. They will own the disease. At that point, the full probing can be completed and a definitive treatment plan can be established for that patient. Now, this is a little different than what we're taught in dental school or hygiene school, because that's not really the dental model. And I thought about this, about why this is effective when explaining everything up front is less so. And my opinion is, it's because what we're really doing here is more of a medical model for infection than what we do with dentistry. If you go to the physician, if you've gashed your arm, what do? They clean it up, they get the debris out of there to remove the chances of infection. They put you on an antibiotic, they suture maybe if it's necessary, and they have you back in a few weeks to see how much improvement has happened. And that's pretty much what we're doing with the two-step perio. It's more of a medical model, and people are familiar with the medical model because most people have had problems, infections, wounds, and so forth. And we're treating this oral infection in the same way. So once they return, then you should have a much more receptive patient, and you can give them, in fact, the actual treatment plan that they need. But you'll be surprised how much improvement there will be in 30 days just after debridement and antibiotic. question then that comes up is, okay, we take them through this, there's a big improvement, they come back in 30 days, but they don't want to go ahead with the root planing. What do we do then? Well, the first question is, should we dismiss them from the practice? And the answer there is no. Remember that your patients have the right to reject any proposed treatment that you give them. Your job is to explain your proposals and why. Be sure they understand what the treatment is for, because if patients don't understand the treatment that you're presenting to them and the purpose of it, they'll never accept it. So you're going to then explain this to them in more detail, and hopefully they'll accept. But if they don't, and they say, well, I want to come back on a 2 times a year basis, but I don't want to do this other stuff now. What should you do? Well, the answer is you should continue to see them as they consent to, because each time they return, you have the opportunity to talk to them about their status and what they should consider doing and why, and to see if you can convince them to move forward. Now, the caveats to that: you better have that well explained in your chart, because if you show that you presented the treatment to the patient, discussed their options with them, and after that discussion, the patient elected not to do the treatment, you're covered. But each time they come in, there should be notes in your progress chart about having presented to them their status, how much improvement or lack of improvement that you see from the previous appointments, and how you discussed what was necessary or highly recommended at that point. The patient has the opportunity to accept or reject anything that we recommend. As those of you who know me, this was driven home to me when I was in my 50s and I had prostate cancer, and had the discussion with my oncologist, and he went through all of the options. And the last option, well, there's surgery, there's radiology, there's radiation, external or internal, there's hormonal therapy, or the last option, you can do nothing and see how you do, and essentially see how long you last. And that didn't sound really appealing to me. And I did the surgery, and God bless, I am absolutely cancer-free now for 15 years. So, but it really drove it home to me. I had the option to not treat what would have been a fatal condition. And that's fine. That's the way it is. But you better have everything explained there. I've been on the Board of Examiners in Arizona. I was on it for 8 years. And that's absolutely true. People that document treatment show that they've explained it, discussed the options, the possible outcomes. If they have a complaint and they can show in their chart that they did these things, and the patient's complaint is they never told me, the patient does not have anything to stand on. If, on the other hand, you do not have that properly charted and recorded, then the patient's word is against your word, but you're the professional and you're the one who's obliged legally and ethically to record all of those things in your chart. So just be sure on those types of patients, on any patient, that you fully record all of your discussions, presenting the outcomes, possible outcomes, and the options, and what the patient decided and why. Now, when they return, every time they come back, you, the hygienist, and anyone else that sees them has the opportunity to discuss their status. And just as your hygienists do with restorative, they're pretty good at looking for these things. They just need to know and understand what their duties are and what your expectations are of them during a recall evaluation. they can help you tremendously keeping your schedule full. And again, other studies on patients and growth and where do patients come from show as much as 50 to 70% of restorative treatment in the typical dental office comes out of the hygiene department. So a healthy hygiene department with good hygienists who know their job, do it well, and understand what we expect from them can really contribute not only to the periodontal success of treating your patients, but also to your overall growth and restorative and any other therapies that you provide. All right, that is a 20-minute overview of two-step perio. Again, this is for those patients that come in that really don't know you, that are the tire kickers. They're not sure who you are, what you are. They've never seen you before. They're maybe coming in because you're having a new patient special. These are those are the ones who are the most suspicious, doubting of any of the new patients that you see. And these are the ones that are the easiest to lose. So just learning techniques like this to not overwhelm patients will make a huge difference in your conversion success rates. All right. I'm open for any questions. If any of you have any for me on this or any other topics that would concern Whitehall. Did I do that well, really?
Hi, Ron.
Hi.
One thing that I've we last year got that AI overjet, and that
Yes.
I still agree 100% with everything you said. But it's a nice thing that when you tell the patient the computer, the software, the AI has noticed you have bone loss. And that's, you come from like I had the old x-rays, little film. You couldn't see anything on this little thing. But, when it's on a big monitor and you can show them where the bone should be and where it currently is, and bone loss leads to tooth loss, it's just another thing to help them understand. Because I agree, you kind of just treat them gently and kind of get them to be educated, and they appreciate somebody's taking the time. But yeah, I agree with everything you said.
I agree too with what you're saying, because there are several programs now that are pretty amazing on showing tissue attachment level, bone level. It's a great adjunct and a great thing to be able to show on a big blown up screen to the patients, because there's nothing as effective as a picture like that. It's so different from when those of us of my generation went through dental school, and it was just x-rays, oftentimes bad x-rays, bad angles, probings may be inaccurate. These new programs are kind of blowing me away with what they're capable of. So use it. I have a number of offices I work with that run scans on every patient. They have progressive scans so that those programs will be able to point out changes in the bone level or in even decay, anything like that. It's pretty amazing. Good thing for the hygienist to be able to use also. Anything else? Any other comments?
Oh, hey Ron, it's Aaron over here. Can you
Yeah,
hear
hi,
me?
Aaron.
Good, how you doing?
Good.
Yeah, so we're using we use Second Opinion in my office. It's Pearl. It's like very similar to the Overjet AI.
Right.
And I was wondering if for example, what the other gentleman was saying with the showing the bone levels and everything, like it gives really accurate measurements with the AI programs. Is that any way a substitute for actual probing? At some point, do you think that could be, or is it, I guess it's like a supplement for now for the clinical probing,
I think
but it really shows the patient what the,
I think it's a great
what
adjunct,
the,
but
yeah.
I would not ever want to go to court without
Right.
6-point probings in
Right.
sequence.
Right.
So yeah, but it could get there. It could get there. They're more and more accurate than well, just even a couple of years ago. So with
Yeah.
all the AI changes, who knows? We may have just unbelievable three-dimensional imaging of hard and soft tissue, which would be astonishing. But it's getting close to that. And even even the color coding is amazing. It shows tissue level, bone level,
Right.
so forth. So it's an adjunct, but we still have to depend on mechanical probing at this point.
And the other thing we started using a few months ago is it's like a dental AI for transcription for the notes. So you can record the conversation with the patient, and then it'll record the whole conversation, like as you're speaking, and it will, you can save that, but then it converts it to a template of your choice into the notes, which I think is a good way to, like you were saying, documentation for um, all the things that could be, if it were to come to like a court issue, you'd have more of a backup showing that you discussed these issues with the patient. There's less likely that, things could be missed. And they're not that expensive. I think the one I use now is like 120 or so a month, but it's, really does. And they have there's perio notes too that you could use. That's an additional feature, but as far as like just the clinical notes, I think that's a good way to record a conversation. You can even review it with the hygienist, seeing where things can be improved in the future.
I agree. Just remember, you need to read them and initial them that you approve them,
Yes.
because that is what anybody would look at, either at a board or a complaint or
Yeah.
a legal situation. But yeah, anything that makes it easier and more complete, I'm in favor of. I played around with ChatGPT a little bit, and I was amazed if you give it
Hmm.
information and just ask it to write an acceptable chart entry, uh, the quality of it. It was really pretty amazing. So if you can do that with a general AI, imagine what you could do with a trained AI for perio and dental needs. So that's really where we're going. Um, and I think that's going to just make it easier for us.
Yeah. And the only other question I sort of had put it in the chat was that so like I just started doing that $99 special. So I think I guess it sounds like even if the patient comes in with multiple issues like periodontitis, they need 4 quadrant scaling and root planning, other restorative work, it's better not to really go over the fees or anything like that the first visit, have them come back. They could still see that as like a bait and switch type situation where you're just getting them in the door, even though you're still doing a cleaning, but maybe they get overwhelmed and feel like you're just trying to sell them on other
Well,
stuff.
yeah, you've got several treatment plans going on if there's dental and there's
Yeah.
periodontal. And the easiest way to do it, of course, you should be recording everything you possibly can, but prioritizing. And if you said to the patient, uh, you've got 1 or 2 teeth that need treatment now, show them why. I recommend we do those
Hmm.
immediately, but I want you to know there are 4 other teeth that also need significant treatment, but we'll get to that after we get these other things under control. So your obligation legally is to tell them, quote, everything that you found, but you don't have to go into incredible detail
Right.
about it, and you can break it down into into a progressive section. So a question just came up too. What do you do if the patient doesn't come back? What do you charge for the debridement? Well, these are typically, your new patient special typically are non-insurance patients. And by the way, the AGA just released a study not long ago saying that now 80% of the people in essentially the working class or in the age group of 20 to 65 have some kind of dental insurance. It blew me away. the numbers have always been more like 55 to 60. Now they're saying it's 80. So there are fewer and fewer fee-for-service patients out there. Your question though, what if they don't come back? What do you charge? If it's a new patient special, it's what the new patient special costs, 99 bucks. You're not going to really do what you would bill out typically as a full debridement because you've only got probably practically about 20 minutes for the hygienist to do whatever she can do. But she explains that. I'm going to do what I can in the time allotted to clean this up, and then we'll get you on the medication, have you back, and see where we have to go from there. That's how you explain it so the patient understands it. Remember what your goal is too. If you're doing a new patient special for 99, 49, 129, whatever, your goal is to get more people in the office. Your goal is to get them in, get them to become a long-term patient, because long-term patients are worth a lot of money to your office. It's not just the hygiene visits, but it's all the dental care that they're going to need over the next 10 or 20 years. And we all have that happen. So you do what your ad said. If it's $99 new patient special, they walk out of there paying $99. Now, when they come back, you don't charge them for that reevaluation. It should be typically about a 30-minute appointment. You explain, you do the periodontal exam, explain what they need, and a lot of times the hygienist can do most of this for you. And of course, you should have already talked to them about any dental care. But we'll see this as the price of getting a new patient, because that's what you did it for. That's why you're running that marketing. And now you're trying to convince them that you're their dental home. So, other questions? It's interesting too. I worked with an office in Idaho for a number of years, and they told me at least half of the new patients that come in, adult male in particular, have periodontal disease to some extent or another. In fact, they said probably 80 or 90%. I think they were exaggerating a little. But that was affecting their restorative treatment. So one of the things that they did, they wanted to, as dentists, our goal is to get these people healthy. And a big part of that is periodontal health. And we all know you don't start putting crowns on teeth with 7 and 8 and 9 millimeter pockets. So if patients have periodontal needs, you want to get those done first. So how important is the profit margin in periodontal treatment? Now, and this is an individual decision. I'm just telling you what this one office did. They decided that they wanted to make periodontal treatment as affordable as they possibly could. So they lowered their fees to a little over the price of seeing the hygienist on an hour. So if they thought it was going to take 4 hours of root planing for this patient, they would charge them 4 times the hygiene fee plus a little bit more. So 4 quadrants of root planing was $400 or $500, which is half of what most offices are changing. And they frankly did it just to encourage people to get through the periodontal part, get them healthy enough so they could do the restorative treatment that they needed. Kind of a different approach, but try not to let periodontal disease be a roadblock for you. It's to your office's and the patient's best interest to have a healthy mouth, especially the periodontal part, because you've all read the literature about the correlation of chronic inflammatory periodontal disease to many other systemic problems. So get them healthy, get them cleaned up, get them healthy. If fees are a major issue, look at adjusting it. Now, let me also say, I hate insurance companies as much as all of you do. So we hate to give them a break. But if you put in a higher fee and then adjust or whatever you want to do, you've always got more benefits for the restorative treatment or aesthetic treatment that they need. Get them healthy, then you can get the rest done too. Other questions or comments? Okay, I hope this was helpful. If you have questions, please let us know. I'd be happy to answer any questions for any of you about this or anything else in the realm of periodontics. No comments? Okay. Thank you very much. We'll see you again next month.